Thanks for joining us for this webinar. We'll just give it a few more minutes while people join the link. We're having people, we opened the link a little early to get people to come on. So we're glad to see you here. I see someone from Tanzania, someone from Uganda, someone from South Sudan so far, so that's really exciting. Thank you for joining us for this webinar on educating religious leaders about family planning. What does research reveal? While we wait a few more minutes for others to join, we would ask that you please introduce yourself in the chat box. Let us know where you're joining from and your organization. That would be great, just so others know who's on the webinar. And then I'll make another announcement in a minute. So thank you for being here. Welcome.
Can we advance to the first slide for Wordly so people have there? Thanks.
Thanks. So thanks again for joining for the webinar on educating religious leaders about family planning. The slide you'll see on the screen is for how you may access interpretation. So we'll leave this on the screen for a few minutes and we'll wait for more folks to join. And then I will come back and say hello again. So thank you for joining. Thanks again to everyone for joining, and good to see Melaine and Richard for introducing yourselves in the chat box. We welcome others to introduce themselves as you join. And the link on the screen is for how you can access interpretation through an online system we have called Wordly. So you can scan the QR code, and then I also put the link in the chat box for where you can go directly to access interpretation, if you'd like to try that. So we'll leave this on the screen as more folks join, and we'll get started in just a few minutes. So thank you for being here. Today's webinar is being recorded, and it will be shared with the registrants from today. So Paula, you will receive it. Thanks for joining from Oregon. I know it's early there. I see Richard from South Sudan, Melaine from Rwanda. So glad to see everyone. Nathaniel, welcome from Cote d'Ivoire. Glad you are here. Nathaniel, if you need interpretation, I hope you can go to the link, and you will be able to access the webinar in Francais. So we're just going to give it a few more minutes for folks to join, but welcome. We're glad you're here. Hi, Skellion. Good to see you. Glad you're here. Thanks to those of you who are introducing yourself in the chat box. We're really glad that you've joined us for this webinar on educating religious leaders about family planning. Sorry that you can't see us, Scallion. I hope that your screen becomes more clear. Today, we're going to be using Wordly artificial intelligence for translation. So what you see on the screen is a way that you can receive written or audio interpretation. So audio interpretation information is available on the screen. You can scan the QR code on your phone, and it will take you to a website where you can either listen or read the interpretation from the webinar, and you'll be able to choose the language you want, such as French. So I hope that's working for everyone. I will put the link again in the chat box for where you can access interpretation. And I hope that folks continue to introduce themselves. So I see that a few more folks have joined from Atlanta, West Africa, from Kenya, from Uganda, from DRC, from Nigeria. So we are glad you are here. And we're just going to give it a few more minutes till we start while folks join. I hope people are able to access the interpretation link. Glad someone has joined from Liberia. It's good to see such a diversity of folks joining to learn about this topic, about educating religious leaders about family planning. I see Bangladesh too, and Malawi. It seems we have people who are here very early in their morning and very late in their day. So we are grateful that you are here and thankful that you have joined us. So I'm just going to give it one more minute, and hopefully people continue to access the link for interpretation, and feel free to continue to introduce yourself in the chat box. We'd love to know where people are joining from. So thank you. I see we have someone who's joined us from Fiji. I don't even know what time it is in Fiji. So thank you for being here. Glad that there are so many folks joining us from different places. If you're just joining us now, what is on the screen is a way that you can access interpretation. There's also a link in the chat box, which I'll put in there again. But I just really want to welcome you for this webinar on educating religious leaders about family planning. What does research reveal? My name is Mona Bormet, and I'll be the moderator today. I'm the program director at Christian Connections for International Health, and I'm based in Nairobi, Kenya. So thank you for joining today from different parts of the world. And I'm pleased to welcome Dr. Agrey Mwakisole and Dr. Jennifer Downs from Tanzania. Their team conducted an open label cluster randomized trial in 24 communities in Tanzania to determine whether an educational intervention for religious leaders would increase community knowledge, demand for, and ultimately uptake of family planning. The results were published in the Lancet Global Health in December 2023. And so we will be discussing four main things: the researchers' methods and findings, concerns expressed in that same issue of the Lancet Global Health about engaging religious leaders as possibly reinforcing existing power dynamics and potentially compromising women's autonomy and decision-making. So did the team find anything related to this? Why they decided to conduct a research study on this topic, and their advice for others interested in linking research questions to family planning projects with faith communities. So welcome again. And once again, if you've just joined, the link for interpretation is in the chat box, and we encourage you to introduce yourself. But our speakers today are Dr. Jennifer Downs and Dr. Agrey Mwakisole. So Dr. Agrey is the Principal Emeritus and Professor at Mwanza Christian College in Mwanza, Tanzania. He's also the Director of Theological Education for Pentecostal Churches of Tanzania and the Chairman of the Interfaith Council that oversees Christian and Muslim dialogue in that region of Tanzania. And then Dr. Downs is an associate professor of medicine and conducts research and teaches at the Buganda School of Medicine in Mwanza, Tanzania. We are super excited about the research they've conducted. We welcome them both, and we'll turn it over to Dr. Mwakisole to start us off. So welcome, Dr. Agrey. Over to you. Dr. Agrey, you need to unmute.
Thank you. It is my pleasure to have this time to explain about educating religious leaders about family planning and what does the research reveals. Next, please. And as you see in our screen today, we are presenting on behalf of many co-investigators from different institutions and different investigators. As you see, we have from Buganda Medical Center, Mwakisle College, Wales, and National Institute of Medical Research, and University of Oxford. Together, we had a good time and do all this research together. And then what will happen? Why did we do this? Next, please. Maybe we want to see why did we decided to do research on promoting healthcare in rural Tanzania. There are different reasons, but main reasons are as follows. Many people in Mwanza reported trusting healthcare guidance from religious leaders more than guidance from a doctor. And also, as we know, in Tanzania, we have two principal religions. These are Christians and Islam. And from the research, as I said, we note that 93% rate religion as very important in their lives. And also, 83% attended religious services at least weekly. So many people in Tanzania are religious doers. I think should be one of the best in a religion in a world that all Tanzanians, they do accept or believe in religious leaders. So it was our opportunity now to find some answers. If it could be easy for us to do research and find some ways of helping people to do family planning. According to, next please. As we said now, in sub-African Sahara, there are other researchers who show that 76% of people reported confidence in religious organizations rather than in other organizations. And also, 51% reported confidence in health systems. But finally, 46% reported confidence in government. So that shows that the results is more reliable for religious leaders to take a time and train others for health issues also. And for that, we have to understand that a critical approach to community level of health, if we want to give our rights and we need to promote health using messages that are compatible and acceptable and also is concordant with religious beliefs. It will help more people to know and to understand about family planning in different ways. As we know that there are different perspectives in our religious beliefs. Each one can interpret the Bible according to the cultural beliefs. So if you can use this one, it will be help us. It can be better for our understanding. Please, next one. As we see now, also to find this to work or not, we build our foundations to the previous researches which we did. One we did in 2012 up to 2016 about male circumcisions, which also it was one way of preventing HIV. We noticed that in that day we did intervention in one day by educating seminars for religious leaders about male circumcisions and prevention for HIV. According to that research, we came to have a result that 53% of intervention communities attended to male circumcisions, while 29% of the communities which was a control attended in a family planning practice. So that it shows that teaching for leaders has a great need, more than what we expected. From that now, the next one which I want to talk much. Next. From that research of male circumcision, many women asked us or requested us to teach something relevant to the women more, because now this it was much related to men. And from that now, we came to find that also there's another important issue is the demand of male of family planning. So we decided to work on it, and that's the Tanzania, which you can show and with the red arrow, with the blue one, so that now we decided to teach about family planning in Tanzania. That's what happened, forced us to find out what do we need now for other people, or for as we did for Christian leaders, so can do also for religious leaders. Okay, what's happened now? Next, please. Next. Now, what are the barriers to uptake family planning? There are different perspectives in religious leaders. So knowledge was one of the biggest gap between men and women. Men are ahead of, we know that men are ahead of the family with minimum knowledge of family planning, while women are being taught in the clinics. But these people, they have a difference within them. And for that, it causes a refusal for male partners to uptake family planning. And also, another issue, barrier, is that uncertainty about compatibility with religious beliefs. Each denomination, each part or each institutions has a different teaching or different perspective about family planning. This also causes the refusal to do uptake of family planning. And these are big barriers three big barriers to do family planning. After that now, after knowing these gaps, we decided to do some interviews. As you see here, is a depth, in a picture, the depth interview of a lady who is our team and another lady who's not our team, trying to do a depth interview to understand these barriers. Please, next. Now, from that interviews, there are some few quotes which we took as one of the obstacles to opportunity for family plannings. One Christian male said that the Bible hasn't said anything about family planning for the Christians. Instead, God himself will say to go and give birth, multiply, and fill the land. These are quotes from one man. And by the same time, one woman say that when God said that you should fill the earth, he did not mean that you should not just give birth haphazardly. He meant that you should get birth to the children that you can take care of in your life. And also, so then do not take care of them. If you don't take care of them, you just leave them out. So that's also a sin. From such words, make us to do much to find more reliable questions, more researchers to understand about it. And also, we did some discussion about this family planning. Please, can you give another one? Now, there's a question. Can we engage these leaders to promote uptake family planning? This is a complex topic. Yes, family planning used as a sustainable health behavior is not just one time. It's a behavior, continuous behavior, which is for primary care interventions. And also, we know that when you do family planning, we have to teach people because this is a decision often depend on partners. When one partner did not understand about family planning or does have a knowledge, it is so complex. So we have to teach them so that they can understand and take care and do decision making freely from themselves. And also more community fears of side effects. If you see there are a lot of side effects that are talking, I think Jennifer will explain much about these complexities which are talking about the family plannings. And also it requires visits to health facilities to obtain contraception. Because at the time we can teach people, but if you are not sure with the facilities to obtain in the facilities, in the hospitals, you are just playing a bad role. So we have to make sure that even there's a contraception in the facilities where around them. And then what we did at the end, we did data collection for 1 year, understanding what we did it, if it is works or not, to find the truth. As we say now, our data collection was in two ways. For those, the control one and the intervention one. To wait to find them if we are together or not. And also at the end, as my time is short, next. What we did now, it was a cluster randomized of 24 communities. 12 was interventions, and 12 were controls. As you see now, we did education seminars and follow-up mentorship session for all Christian religious in the intervention part. And what we did, we just choose, as we randomized churches, and also we invited to see 3 men and 3 women to each church, which we took as our intervention groups. But at the same time, at a control, 2 communities enrolled at a time and randomized together. And then the control one was be done to the end and finding the results from this teaching which we did for them. The last one is how we get those places in our research. Please, can you go for the last one? Next. Okay, intervention. Also, we did in disciplinary education seminars about family planning to Christian religious leaders. As you see, this picture shows now this nurse is teaching the participant at intervention one. We have 3 sessions of training them. The first one was the major themes which you got from interviews. Previously, we did interviews and get some discussion, some answers. And from that one, we taught them and showed them and discussions which we got in the interviews. Second, we did a training about historical and background of tradition of the Bible. What the Bible is talking about family planning and how it works. And the last one, it was a medical teachings about the menstruation and various family planning techniques, family planning ways which you can work, we can do it, and also training about side effects of family planning. Now, at the end, next. Now, here are those villages, communities which we did. Also now we have 12 for intervention and 12 for controls. Those you see in a red sign, red dots, are the intervention sites which we did. And those with blue dots are for controls which we did in different ways. All of this, it is in Mwanza region. Thank you for hearing me. God bless you. So now I want to take this time also to invite Jennifer Downs, Dr. Jennifer Downs, to continue with other training which it's in our way. Thank you, Jennifer. Welcome.
Thank you, Dr. Agrey. Next slide, please. I'm delighted to be here. Many thanks to Christian Connections for International Health for inviting us. So with this trial, we collected data at the level of each community's health facility. You just saw the 24 communities, and we collected 2 years of programmatic data to measure what you see at the bottom, the primary outcome, which was the uptake of contraceptives that were dispensed at the health facility in each community. And we collected data from 1 year prior to the intervention, and then prospectively for 1 year after the seminar, the educational seminar was delivered. The other data that we collected were in-depth interviews, which we did with community members and religious leaders. Next slide. And just to give you a sense of the types of communities where we were working, they were small and pretty rural. So you can see that for the 12 intervention communities and 12 control communities, the total catchment area, the population size was around 10,000 to 12,000 people. We were collecting data from small facilities that had about 4 clinicians employed, but they were able to prescribe and dispense contraceptives. Contraceptives are offered free of charge by the Ministry of Health in Tanzania. And you can see from this graph, our baseline data before any intervention showed that about 7 to 9 people per week on average were visiting these facilities to seek contraception in the year before our intervention. Next slide. This is a complicated figure, and if people are confused, I could come back to it, but I want to give you the big picture. You're looking at the control communities in blue on the left, and you're looking at the intervention communities in red on the right. The dots show the data from the year before the intervention, and the triangles show the year after. So you can see that there was an uptake of contraception. Contraception is on the y-axis. An uptake of contraceptives in control communities, the blue lines go up, and also in intervention communities, the red lines go up. You can see that the red lines go up more. So there was a greater uptake of contraceptives in the red intervention communities. And overall, looking at all 24 communities, there was a 19% greater uptake. Next slide. You can see, though, that there was a problem with COVID-19, which happened exactly in the middle of our trial, shown by the blue lines. You can see that when COVID happened, uptake decreased somewhat. If you were to only consider uptake before COVID, we saw a 30% increase in uptake of contraception with this intervention. Next slide. This shows some characteristics of people that came to the health facility seeking contraception in the year after the intervention. The thing I want to point out is what is in the red box, which is that the health professionals asked people coming for contraceptives, who was it that advised you or gave you information about family planning? And you can see in the first column, the intervention communities, over 40% of people said, I got information about this from a religious leader. And that was compared to less than 1% in the control communities. Next slide. And this illustrates the rate of information being provided by religious leaders. So that you're seeing along the x-axis over time, the percentage of people that said, I got information about family planning from a religious leader. And it's before COVID and after COVID in these two images. The main point of this image is that the line keeps going up. So you don't see religious leaders giving information immediately after this educational intervention, then sort of forgetting about it, which would be shown by lines going up and then becoming level. Instead, you see these lines keep going up throughout the year after the intervention. Religious leaders kept advising people in their communities and kept telling people about family planning, and people who came to health facilities reported that. Next slide. So we also have done a lot of work with qualitative data to understand community perceptions of this intervention. We've done close to 100 in-depth interviews by this point. We've interviewed both religious leaders and community members. We've done these interviews both during the trial and recently. In fact, right in the last month, we're continuing to do some long-term interviews, now 4 to 5 years after some of the earliest interventions were provided. Next slide. I want to highlight 4 main points that we have found in this qualitative data. The first one is that religious leaders felt that this intervention equipped them to consider family planning in the context of their faith. So a male religious leader said, actually, the Bible has not kept quiet. It does give us information about family planning. It says that you need to be able to take care of your children and provide for them. Another religious leader told us he teaches about family planning, how it fits with the Bible, but when he gets asked questions about medical aspects or specifics about contraceptives, he always advises them to go to the hospital where they will get advice on how these method works. That was really important for us. A lot of leaders said this. I think this speaks to the fact that they recognize the limits of their expertise. They learned more, especially about how family planning relates to faith. But when it came to technical questions, they never thought they were experts. They would refer ultimately for women and men to make decisions about family planning in conjunction with the people at the hospital, the health professionals. Next slide. The second major point was that women who came seeking family planning expressed a lot of optimism and hope because they heard teaching that helped them to reconcile their religious faith with the need they were experiencing, the real need of providing for the children that they had. So one woman said, I felt relieved when I heard about family planning from a religious leader. It was a blessed thing to encourage it. She talked about how it was the environment made it hard to have many children. After hearing about this, she went and talked to her husband. She said she wanted to use contraception. She was enabled to discuss this topic with him for the first time, and he agreed. We heard many, many stories of people, women who for the first time were sort of able to put this together, to broach the topic with their husband and to seek family planning. Next slide. The third thing that we have really sought to understand is whether there is any evidence that religious leaders' teaching compromises women's contraceptive autonomy. So, of course, religious leaders are very influential. They're very trusted. And we've tried in all of these interviews to understand, has there been any reports by people themselves, or have they heard reports where a leader pressured people on a decision about contraception? We haven't found it. So here's an example quote. The religious leader just said she wants everyone to decide according to her time about family planning. So if a woman would like to follow it, family planning, she will follow it. And if she wants to ignore the advice, she will ignore it. We heard a lot like this, that ultimately the decision stays with the women and the men. Next slide. And finally, we saw that this intervention didn't only stay in the religious institutions, it actually extended beyond the religious institutions. We heard many descriptions of people talking in their communities about the new knowledge they had had. One person said, I haven't heard it in church, or maybe others said, I don't go to church, but there are women's groups and women in my community are talking about this and saying that family planning is good and safe. So we saw that this intervention really reached beyond the religious institutions into communities. Next slide. So we conclude from our trial, we conclude that education for religious leaders led to an increased uptake of family planning. From the complicated figure we showed, it looks like the uptake was about 30% before the pandemic. Overall, accounting for the COVID pandemic, there was a 19% increase in uptake of family planning when religious leaders were educated and then brought that knowledge to their communities. We estimate that if this was rolled out in Tanzania alone to Christian and Muslim leaders, this could lead to about 1 million more women who no longer would have an unsatisfied demand for family planning. Next slide. We recognize that uptake of family planning is only one indicator in a breadth of goals to improve sexual and reproductive health for men and women worldwide. We measured uptake of contraceptives because that was the easy thing to extract from the logbook book. But as you saw, we did a lot of work on trying to understand more about knowledge, trying to understand how this intervention affected women's autonomy, but also their ability to make decisions because they had increased knowledge about family planning. We have additional goals as well, which are helping to make sure that we empower everybody to achieve their reproductive goals. And we see that by increasing knowledge in communities about family planning methods, and even about how they relate to faith, that is a way to help people to achieve their reproductive goals. And then finally, one of the broadest goals of all is promoting the health of mothers and children. And that's a goal that we're working on now, following up in these communities long-term to understand how this intervention affected health. Next slide. We found no evidence that partnership with religious leaders reinforced power dynamics or compromised women's autonomy. As you saw in the qualitative data, leaders consistently referred community members to health centers when they had questions, when they needed information, and really to make final decisions. And no person to date has described any experience of coercion or loss of autonomy, any undue influence in themselves or others. Next slide. We are now going back to these communities to working again in the health facilities to measure some health outcomes in mothers and babies. So outcomes like birth weights, maternal and neonatal complications that can get at bigger questions of how this intervention might actually promote health in these communities. And secondly, this is a picture of some of our recent work. We are working to expand this intervention in partnerships with Muslim communities. So here you see one of our pilot seminars in Muslim communities. The structure of the seminar is similar, where we talk about how family planning can fit with faith. And then we bring in a medical professional, an obstetrician gynecologist, to talk about the basic aspects of contraceptives. Next slide. Finally, I just want to say thank you. We feel tremendously grateful that we had the opportunity to conduct rigorous scientific testing of this intervention, and then that this trial was able to demonstrate that this is a highly effective strategy to promote women's health and decision-making in sexual and reproductive health in communities. It's been a joy to do this work. We feel we have been guided by the community, beginning with the women who said, "When will you come back and talk to us about a topic?" To continuing now as we learn how we could make this better. How can we strengthen the intervention the next time around? And here's a picture of our multidisciplinary team. You can see it has Christian and Muslim religious leaders, doctors, public health officials, qualitative researchers, and it has been such a joy and honor to work with these amazing people. So thanks again for inviting us. Thanks for joining the webinar, and we would love to have a discussion and answer questions.
Thanks so much, Jen and Agrey. We're going to move to a time of Q&A. So if you have questions, please put them in the Q&A box. So we can probably stop sharing the slides, and then we'll just have a time for us to discuss. So I'm going to start with the first question I see, which seems to be more of a comment. But it said, from the findings, the religious leaders refer women to health facilities for more technical details. I wonder if in a future study, you may want to include a self-care method like DMPASC, which a woman can self-inject after visiting the health facility. It will definitely help the woman's autonomy. Any response or comment, Jen?
Thank you. That's such an interesting idea. I think that would be fantastic because, of course, there are still limitations when women need to visit health facilities that don't have a lot of bandwidth or a lot of workers. So I agree that would increase women's autonomy. I think it would be good to ensure that they had ways of making sure that their knowledge was strong about this contraceptive before they started using it. But I think that would be a fantastic idea.
Okay, thanks, Jen. There's a question from Mr. Kamau that says, why such a big proportion, 29% of respondents who did not want to reveal their source of FP information? I'm not positive what slide he's talking about, but.
Oh, Agrey, I think you're talking. You're on mute.
Sorry, I was trying to find this because I think as this 29%, which is planning, we're talking the previous research we did from male circumcisions. And you show that the control one had 29% percent of the communities was the division in the communities. And 53% are those who accepted after being taught. But the one, the control, we didn't teach them. I think that's what he meant. I think that's 29%, which shows in our graphs.
I could add, they're also in the data that we showed that 40% of people said they were advised by a religious leader versus 1%. This was asked by a very careful listener. Thank you. Down at the bottom, the last line was, there were 29% of people that we didn't have that data, no response on who advised them. That actually is not, I don't think it reflects, for the most part, that they didn't want to answer as much as that the people collecting this data were asked to collect it in a small additional logbook, and were sometimes, the data was not perfect. The data was not incomplete. They were not members of our study team. They were the nurses working at those health facilities. So I think they did the best they could, and we had missing data.
Good. Yeah.
Good point about all the different people involved and data issues. I'm sure we could get into that. There's a question from Martina about, was the education of religious leaders on family planning exclusively focused on married couples, or did it talk about family planning for anyone regardless of marital status? If it was for anyone regardless of marital status, how was that received or navigated?
I think as we said from the beginning, that we teach them all together, and also it was very easy, acceptable for those married after being taught to go and do family planning. But the first time it was very hard especially for men to accept about family planning, because they didn't have enough knowledge. They just take it, as the Bible says, in a small verses for men. But after understanding now the knowledge, what about the family planning? They come together and realize to go. But as you said, culture also affected much this married couple to go together to the facilities. They're just accepting, okay, their wives to go, but not us to go to the facilities. Not much, and we didn't teach, or we didn't say about that also. I think that's all. Maybe if you can understand the question.
Yeah.
Jennifer, what?
Yeah, I agree. I would just add that so the intervention was provided to religious leaders, not couples or not community members. And our goal was to equip religious leaders to then take the knowledge that they gained from the intervention and apply it how they wanted and teach how they wanted. And some religious leaders talked about meeting with married couples, for example, but other ones talked about wanting to do premarital courses or wanting to educate adolescents. And we did not say, like, you have to use it this way. Our goal was really to equip them with the knowledge that then, you know, both how does this relate to what the Bible says, and how does this, and then what is contraceptive, what are contraceptives, how do they work? And then they were the ones that implemented in the ways that they saw fit. And there's a question that asks about, did we teach about natural methods? So and yes, we did the same way. We taught about methods ranging from you know, abstinence, withdrawal, or calendar method to the medical contraceptives that are dispensed at the health facility. We taught about all of them, and we had Catholic leaders also attend, and I think some of them would choose certain methods they would teach about. But our goal was not to say who has to teach about what. It was to give the information and then equip the leaders to be able to address these issues in their communities.
Thanks, Jen. I think people based on that might have some questions about how you made decisions of what you included in the curriculum. And I did put a link to the curriculum that you all used in English and Kiswahili. I put the link in the document. And I also put the link to the Lancet article so people can see that. There seems to be a follow-up question about, what do you mean by women's autonomy? How do you approach that or promote that in the African Christian context? If you could just clarify when you mention that, what you might mean. Thanks.
Is that me? I think that's me. By autonomy, I think we're meaning really the right to decide for themselves about their health and about their sexual and reproductive behavior. Yes, and I see a question in the chat also. Like, yes, women, they're in some of these societies, women's equality is not assumed, right? So, and I think it would be exciting to work with sort of the strategy of working with religious leaders to think about ways we can start to address some of those things, to talk about, well, what does the Bible have to say about that? But regarding women's autonomy for family planning, we were really focusing on the autonomy to make a health decision for yourself and to have the knowledge to understand it and think about it and decide. And in some cases, in a lot of cases, we found that this intervention enabled for the first time discussions between partners, whereas before women had been afraid to broach family planning, or maybe some were using it secretly. This intervention enabled that to come out into the open more, and in that way increased women's sort of autonomy as well. That's a very complex process, absolutely.
Yeah. There's two questions that I think are related to each other. So they both have to do with, so you have this research, you have these findings. Some say this might be a difficult topic to work with a community. So would you suggest layering or sequencing activities to build a relationship and then this comes later? Or does that matter? What has the research said that you might suggest if someone wants to do this type of intervention in a faith community? So there were at least two questions related to that.
Thank you, Mona, what you are talking about. Yes, it can be difficult to do it, and also it can be easy, according to the approach which you are using to go to deal with the community. And for example, in our research, most of the leaders of the research were Christian leaders also. So we use the pastors and other key leaders in the church to go to the community and talk with them. So that's why also for us it was so easy. And also we do the rapport between key leaders of the organization around the village where we are doing. That's also one of the best way to try to find the best way to teach them by using the organization which are around there, but also by the same people, not just of scientists people or doctors, because now we're talking about faith. And also, so for that now we have two teams, those with religious education, theologians, and also with doctors. Those doctors were being introduced by the pastors. Maybe that's why I want to answer this question.
Thanks, Dr. Agrey. I think your final point, I definitely agree with that. The importance of ensuring that the messenger is trusted and that they develop that relationship and refer people and go together. I've seen that work in places too. So thanks, Dr. Agrey. Jen, anything to add to that? Otherwise, there's many more questions.
Just that this, I mean, the whole project was led by Dr. Mwakisole and his team, who have so much wisdom in sort of connecting with the leaders of the communities where we work and doing it very carefully and thoughtfully. And I think that was having partners like that is critical for a topic like this.
Okay. One of the questions is related to women's autonomy. So it says one challenge is getting agreement from male partners. It seems like making a faith-based case is helpful for this, but it doesn't change the basic dynamic or encourage access to family planning for adolescents. Do the researchers have any qualitative insights on these topics, even though it wasn't a part of what was measured?
I can
I'm
start.
not sure if you
maybe Agrey can add. That's a great question. Thank you.
So I'm trying to think about the question before I answer it.
Good one.
Yeah, maybe you can start, or maybe
start.
Okay, what I'm talking about first of all, autonomy. Autonomy is that we didn't force women, or we didn't manipulate them, you see, to do the family planning. But we teach according to the basics of teaching, scientific teachings, Bible-based teachings, and also the outcome which we did through other research, other interviews which we did. So we just give them a free to decide, and without any monopoly teachings, you see. That's what we did after that. So from that, it is a person to decide, not we as teachers to force them to go to family planning. I think that's what maybe I can, so Jennifer, maybe you can
I
add
have
from
something
that,
to
or
add
maybe I
about
can.
that. Yeah, I think from the qualitative data, one thing that we heard very often was that in general, at least for this part of Tanzania, women tend to know more about family planning than their male partners. And that's because they often it's that they bring their babies for vaccinations and things, and a nurse might stand up at the clinic and say give a little teaching about some of the contraceptives. And it actually becomes this sort of tension that's in some ways almost embarrassing for the partners. They don't know very much about it. There's a lot of suspicions in the community about dangers and whether it can lead to cancer or children with birth defects. And so men don't have very many opportunities to get knowledge about contraceptives. And so the question asked, like, can approaching this from a faith-based perspective help? Yes. And even it's for the first time, sometimes men are hearing about family planning from their religious leader about the faith aspects of it, but even some of the basic questions about the medical aspects, like that this has not been associated with birth defects, and that this is actually helpful for the health of mothers and babies. Some of those basic things that they may not know. And so women's autonomy is a challenging issue, but we found that elevating especially men's knowledge, it elevated everyone's knowledge, but it is maybe there was more to gain for men. And that in and of itself sort of enabled these discussions and enabled like a more equal discussion between partners about this topic.
Okay, thanks. I think we have time for just a couple more questions, so I'm going to combine a few that I think are related. There's a couple that really talk about some religions or denominations seem to be against family planning, perhaps because they feel that it goes against God's plan of procreation. And so I think this might be related to Genesis 1:28, you know, go forth, be fruitful and multiply. So how do you feel that, you know, someone said that it may be a threat to them if their family size reduces. So how did you talk about, you know, it says be fruitful and multiply, but then how did you talk to people who had that belief in terms of family planning, and what does that mean? In Christian context, I don't think this was just Christian, but that's how I interpreted the question. So I don't know, Dr. Agrey.
Yes, and myself, I was one of the people who understand that there are other religions which they don't want about family planning. After my research, I came to that every religion does not fight with family planning, but they fight at the methods of family planning, not family planning as a way, because every denomination, every religion wants the gap of children is very important for every religion. There's no any religion who wants after 1 year another baby, but they are using different ways of family planning. But what people are fighting is the methods, for example, contraceptives and other methods, but they are using other methods, because traditional methods, most of the people are using traditional methods. So I don't argue, or I'm not supporting that, and also I was supporting that there are other religions which are fighting they're against with family planning. No. And for example, maybe I can mention, they are talking about Roman Catholics. But Roman Catholics, they are not against with family planning. They are against from contraceptives which they are using, only that one. And it started when the medication started, is where now these Roman Catholics try to underline the way how their believers can do family planning. And also another thing, it was the definition of family planning. Most people, they thought that family planning, it means excommunicating from birth, not child spacing. But when we're talking about family planning, we are talking about child spacing. I think maybe now Jennifer can add and give you the that. Thank you.
I agree with that. And I think the other thing I saw you and your team do, Agrey, was it was like the first verse everybody can think about is be fruitful and multiply. But then you all would draw out other examples in the Bible of people that didn't have so many children, and talk about passages from the New Testament that talk about being able to provide for your family. And so that I think helping people to see, like, we can be fruitfully and multiply, but we also have an obligation to provide for the children and have children that are the one amount that we can care for. So I think that was helpful. And I would just add in the work we're doing now among Muslim communities, similarly, there are passages in scripture that support spacing children. And so pointing and discussing some of those has been helpful.
Yeah, so we have a lot more questions. We've tried to answer some of them in the chat box, but we're running low on time. So I would just ask Jen and Dr. Agrey, do you have 30 seconds of closing, anything else you'd like to add? And then for those whose questions we did not get to, hopefully the resources we provide will answer your questions. And if not, we will look at the questions that we didn't get to and we will try to answer them. And as long as you're registered and we have your email, we can try to respond to you. So thank you for your time. But Dr. Agrey, Dr. Downs, 30-second closing statement.
Thank you. But okay, let me answer somebody at the end here. I say, Agrey, is it a child spacing only? Real. What about limiting the number of children? I think if you do spacing, we didn't fight with number limiting. We're just finding the spacing so that a child should have a good health and a mother should have good health. Not limiting of the number. That's it. It was not our objective. Thank you.
I don't have much to add. I saw people asking for the paper, which we would, I know Mona is happy to share, and we'd be happy to, feel free to reach out to us if you have questions. We want this curriculum to be available. It is available in English and Kiswahili. And just, we hope that it will be something that can be, that other people will find to be empowering for communities, for entire communities, in thinking about this topic. So thank you so much for inviting us.
Yeah, so thank you, Dr. Agrey and Dr. Downs, or I should say Dr. Mwakisole and Dr. Downs, sorry, for sharing about your work. The Lancet article has been included multiple times in the chat box, as has the resource link to the curriculum in English and Kiswahili. We've also put a link to a 1-minute, 1-question survey in the chat box. We'd love for you to complete it, please. If you are part of a faith community and want to stay engaged in discussions on faith and family planning, we encourage you to join CCIH's Family Planning Listserv, where we share information. And I also serve as the co-chair of the International Conference on Family Planning Faith Subcommittee. That's planning faith participation in the November 2025 meeting in Bogota, Colombia. So I will put links for how you can learn more about those items and how you can get involved and stay engaged in this topic. We're really grateful to Agrey and Jen for sharing their work and the work that they continue to do in Tanzania. And we're thankful to all of you who joined and asked questions and really engaged. Once again, we're grateful for that. We're sorry we didn't get to all the questions, but we will try our best to follow up. So thanks everyone for joining. And I hope you all have a wonderful rest of your day. good afternoon from East Africa, or good evening,
Thank you.
or good rest of your day wherever you are in the world. But thank you, everyone. Bye.
Bye. Thank you.